Good afternoon, and a very warm welcome to today's episode of our talk show series, Let's Talk Primary Healthcare. As you can see, today we're in a celebratory mood. First of all, because today's episode marks the launch of our third season of our talk show series. Over the past 2 years, 2,000 of you joined us live in conversations about primary healthcare policy. And our episodes also collected 2,500 views on the YouTube channel of the WHO Regional Office for Europe. We look back on these conversations with pride, and these numbers demonstrate that there is continued interest and need to get together in these conversations about the burning topics of primary healthcare policy. The other reason why we are in celebratory mood today is because tomorrow is International Women's Day. And with this beautiful, fresh spring bouquet of flowers, I would like to congratulate all the women and men out there making our world a better and more equal place. This is nowhere more important than in primary healthcare, where equality and gender equality in particular are important determinants of health. And with that, let's turn our attention to today's episode. Today, we're going to talk about traditionally well-performing primary healthcare systems and the challenges they face. I am delighted to have panelists from Spain, Canada, Lithuania, and the European Observatory. These are countries we often refer to as models when we want to demonstrate how to strengthen primary healthcare, how to create strong family medicine grounded in values, and how to move towards multidisciplinarity to address upstream and social determinants of health as well. But we are hearing that these countries are facing challenges, and we're increasingly hearing the narratives that demand is increasing very fast and it's impossible to satisfy it. We're hearing about grueling workloads, burnout of the health workforce, and difficulties motivating young professionals to choose primary healthcare as a profession. Why is that? Is this an impact of the pandemic, a short-term impact we could easily address? Or are these problems reflecting long-term structural challenges of systems designed decades ago for different populations and communities, for different set of health problems and expectations? Is it possible that primary healthcare in these countries is a victim of its own success? These are the questions I will be asking our panelists in the coming hour, and afterwards we're inviting you to join us in 2 breakout rooms in English and in Russian, moderated by my colleagues, to hear your views and reflections on the very same questions. In the meantime, the chat is already open, so please come by, say hello to us in this chat. And my colleagues have also prepared a range of resources to share with you in the coming hour. With that, I am delighted to welcome and introduce our panel. Hello, everybody. Thank you for joining us today. Let me introduce our guests. I start with Dr. Catherine Rouleau, who is the Global Primary Healthcare Lead for the Office of Health Systems Partnership at the Department of Family and Community Medicine, University of Toronto, Canada. Welcome, Catherine. Dr. Kristina Zuteliene is family doctor and assistant professor at the Family Medicine Clinic of University of Health Sciences in Kaunas in Lithuania. Dr. Maria Pilar Astier is a family doctor and also technical officer on quality and patient safety in the Catalan Health Institute in Spain. And Dr. Josep Figueras, who needs no introduction, is the director of the European Observatory on Health Systems and Policies. So without much further ado, let's dive into our first round of conversation. And in the introduction, I used this question, and we entitled our talk show with this provocative title, in well-performing primary healthcare systems, is primary healthcare a victim of its own success? Yes or no? I'd like to hear now your elevator speech. And Pilar, let's start with you.
Good morning, good afternoon, good night to all. Thank you very much for inviting me to join this amazing panel. I'll share my experience as a practicing family doctor in Spain. It's sure we will learn together to build a stronger primary health care in Europe. Regarding Spain, primary care is the first contact point for patients seeking medical attention is free of charge, comprehensive and integrated care to almost 90 to 95% of citizens, has a critical role for promoting, preventing disease and managing chronic diseases, and was developed in the 80s in the spirit of the Declaration of Alma Ata. It consists of public primary healthcare teams staffed by multidisciplinary professionals in a given territory. Its success has led to improved health outcomes and reduced healthcare costs, with high rates of citizen satisfaction and trusted relationship with the community. However, the model is being at risk in the aftermath of the pandemic, lack of funding and not being able to implement in time innovation to transform the system to face current health needs in new social contexts. If we do not address soon these challenges, the quality and safety and the role of primary care in the systems is at severe risk. In Spain, a family doctor, as me, will have to visit 40 to 50 patients a day with 5 to 7 minutes per patient since many years. There is no regulations and the limits on the agenda and no economic compensation regarding to visit 20 or 60 patients per day. Most of the patients are older patients with multimorbidity, polypharmacy, with increased complex care demands, but inefficient tax distribution among primary care teams with lack of care coordination. Therefore, burnout and early retirement among family doctors is the way things are now. Consequently, family medicine is not an interesting specialty for young practitioners. Pandemic delayed problems and increased emergency visits in most of Spanish regions. Spain is not a unique healthcare system. It has 18 public provision regional health systems with large disparities in per capita investment from 2,000 euros of Basque Country to 1,400 euros of Madrid region. And even more, there is a public funded with private provision health system for politicians and civil servants. And that leads to a sociological skimming of public primary care population, and even worse, a high distance in between the reality of primary healthcare and the decision-making context. Then, yes, it could be argued that primary healthcare in Spain is a victim of its own success. However, without a plan to address main problems, the investment may be useless in long term. Money, today's bread and tomorrow's hunger without a plan, I think. Thank you.
Yes, indeed. I like how you ended with that metaphor. And let me just pick up one statement from yours of how Spain, the fact that there are so many people going to primary healthcare for these complex conditions, that in itself is a success that in many countries we are not seeing because people prefer to turn to specialists. So this is in a sense in which Spain has really managed to build the trust of the population and the competencies of the health workforce to be able to handle these complex conditions at primary healthcare level. So the question becomes how we move to the next level. Catherine, how is it in Canada? Is primary healthcare a victim of its own success?
Thank you, Melita, and thank you for this invitation. I would say I think Canada shares some of the both successes and challenges of Spain. We have strong family medicine. We have an expectation from the population that they will receive high quality, effective primary care. But we have a system and a model of care that is actually largely organized still today as a solo practitioner model, which is paid fee for service. And that is not really well adapted to the care for chronic diseases and complex concurrent conditions. And so it's a little bit, you'll remember when we were preparing this talk, it's a little bit like we built a house for the wrong purpose. And now the house is not, we need to renovate. We don't need to knock it down, but we do need to renovate. And interestingly, often the politicians and the policymakers focus on the front of the house, the emergency room, the long wait lists for knee replacements and hip replacements, which are, of course, very important, but they fail to capture the importance of the foundation of the house, the pipes, the electricity, and the kitchen, which is, I think, where primary care and family medicine lies. Over to you.
Yeah, indeed. Today it seems like we're full of metaphors. We have another very, very strong one. Christina, with that, let's come to you. And Lithuania, of course, embarked on this transformation and strengthening family medicine and primary healthcare in more recent times. How is the situation in your context?
So thank you, Madam Chair. Welcome, everyone. Thank you once again for having me on this webinar here today. I'm very proud to represent Lithuania here and share our context and experience. So in order to understand better our context, I have to mention that in Lithuania, we're celebrating this year 30 years of family medicine. And throughout the past 30 years of family medicine being a specialty, it has been increasing in popularity by medical students. It has been gaining more and more trust from our patients. It has been representing great unilateral healthcare results, and this is all due to our hardworking teams every day in our primary care practices. Also from our context, we have about 2,000 family medicine physicians currently practicing in Lithuania, and those 2,000 physicians serve around 2.5 million people. So it's quite a good ratio. However, with the population getting older and with multimorbidity becoming more and more prevalent in our country, we are too not an exception, but rather a rule. We're facing heavy workloads. We're facing lack of financing, lack of proper policy, and yes, this has become partially why we feel like we are a victim of our own success.
So it sounds like that there are similarities in all of the countries. Investing previously in primary healthcare and family medicine enabled us to build population trust. Demand has been increasing, and now we're facing challenges to adjust it to the current situation. We're going to get back to this, but before we do that, I would like to broaden the discussion a little bit. And Joseph, here is where I bring you in from your perspective, looking at many countries simultaneously. Primary healthcare functions as part of the broader health system and part of the broader social and economic system. Last week you participated in the high-level forum on health as part of the well-being economy, and primary healthcare plays a very important role in that. What are some of the lessons or what are some of the discussions that bear on this conversation from that perspective? And is the observatory working on anything interesting in this regard?
Thank you, Melita. We always work on interesting things. Thanks for bringing me on board. Yes, indeed, the argument there is that health is a contributor in itself on well-being. People want to be healthier. But also health and health systems are key on the way that they impinge on other economic factors. So it's this concept of health in all policies. This is many determinants of health are outside the health sector. But what we argue now, we argue in this policy, in this publication, which is in the web now, making health for all policies, harnessing the core benefits of health. We're saying that health is good also for all policies, for other policies. Healthier population is a less poorer, it's more productive, it's gender equality and equality in general. Health systems are important for the environment, are important for productivity. So what we are arguing is that it's not only determinants on health, but also how health has an impact on a range of SDGs. So from that perspective, obviously, PHC is fundamental. It's fundamental because we have plenty of evidence about the impact of PHC on health outcomes, and therefore health outcomes have this impact on economic development, on equity, and so on. Talking about equity, PHC has at its core equity. Many of its policies are towards equity within different population groups, with targeting vulnerable groups. But also, there are issues around, there are objectives around universal access. We do know that universal access, even if the system did not improve the health of the population as it does, the mere principle that you have universal access to the health system brings you satisfaction, brings you well-being. But not only that, we're talking about participatory models, which are linked with well-being. We're talking about patient-centeredness, which are linked with well-being. And of course, in a broader primary healthcare concept, primary healthcare itself is not only aimed to strengthen health, but also to act on a number of multi-sectoral determinants in its own community. Back to you.
Indeed, these are very thought-provoking issues, and if we think about what's happened in well-performing primary healthcare systems, countries really invested in getting the clinical competencies right at the beginning to be able to handle an increasing range of complexity at the primary healthcare level and expand resolutive capacity. But in recent times, that has also gone along with the recognition that addressing social determinants of health in primary healthcare setting is absolutely critical to succeed for this set of health problems, non-communicable diseases, etc. So primary healthcare is growing, doing more and more clinically in the psychosocial determinants of health. People trust primary healthcare. People increasingly seek primary healthcare. And then are we keeping up with supporting our primary healthcare workers with resources to manage this success? We will come back to these very important conversations, but before that, I would like to just pause and take a detour to consider what are the main pillars of success in these three countries that make primary healthcare powerful and successful in your view. And Catherine, let's start this round with you.
Thank you, Melita. It's nice to be focusing on the pillars of success because you're right that we sometimes, especially these days, go straight to all the problems. I would say in Canada, for sure, the strength of our training in family medicine is one of the important pillars, and not just the quality itself, which is remarkable and has been the object of a lot of reflection and intentional investments, if you will, from the educators, but also the fact that we have an accreditation system of our education program that really ensures consistency in all of the training programs, which in Canada are all linked to universities. And so this element is not just the quality of training, but also a reflection of the social accountability of the medical education and an understanding that we have a responsibility to respond to and demonstrate an intentional response to the need of the community. So that's one pillar. I would say the other pillar is the expectation that 50% of our medical workforce will be positioned in primary care. We're having some difficulty reaching that these days. We'll come back to that. But the assumption is there, the recognition that that's what we should be working from. And maybe the third one, I would say, is this whole notion of patient-centered and people-centered practice, which originates in our country all the way back to Ian McQueenie and has been, again, cultivated and is really a central part of the way we teach and practice family medicine. Maybe I'll stop there.
Those are very important points, in particular, very, very strong training in family medicine and nursing and patient-centered value practice grounded in values. Christina, from the perspective of Lithuania, you already mentioned quite a number of strengths of your system in your elevator speech at the beginning. What would you like to highlight here as the pillars of your system?
So I would like to second the notion from Professor Catherine and Canada about the training and the importance of education. That has been one of the cornerstones of success in Lithuania as well. Looking back at how family medicine was started in Lithuania, we really have to admit that we had strong cornerstones for training. We had people going to various countries, including Canada, and bringing back the best practices in training back to Lithuania, composing the sort of international outlook into the national context. And this is how our programs really achieve their success. Therefore, we had well-trained physicians and well-trained servants of the healthcare, so to say. Now, the second thing that I would like to mention is the professional autonomy and team autonomy. Why that is one of the most important pillars was that in previous years, the way a Lithuanian healthcare system would function, there wouldn't be such substantial primary care and family medicine wouldn't exist. But after we regained our independence, we realized that we need to have strong family medicine teams and we have to have family medicine specialists that would be independent from other specialists, so to say, and really be empowered and show leadership in terms of primary care provision and prophylactics as well. So that has been something that our physicians and our teams have taken strong pride in, and the interprofessional collaboration has been really strong throughout this as well. I would also like to mention that at the very beginning, what was quintessential was that we had a national health strategy. For being a new country after regaining independence, we had all stakeholders sit together, political parties, academia, practicing physicians, and we really looked at the perspective back 30 years ago. So the perspective was that we want to have a healthier society and primary care should be at the cornerstone of this. That agreement enabled primary care to be fostered and grow up as it is right now. However, currently we have some movements in a different direction. We have our reservations about this, but that's a topic for another discussion, I guess.
Those are very important additional points, having a very clear vision for the development of primary healthcare and professional autonomy and team autonomy. And indeed, we know this from research of successful teams, not just in health, but more widely, that autonomy is a key component of successful intellectual work as well as innovation. With that pillar, what additional factors we can tease out from the Spanish experience?
Regarding Spain, there are lots of similarities with Canada and Lithuania. The main pillar is the fact that each citizen has a GP and a primary health care nurse responsible of the medical care, so therefore longitudinality is guaranteed. Competent professionals, family and community medicine specialists for 4 years programs in 1978, and family and community nurses specialization with 2 years programs since 1910. An increasing number of young professionals with advanced competencies that they are our future. Provision of primary care services free of charge at the point of care, including all kinds of visits to health center, home visits, and the referrals to hospital specialist care, hospital emergency referrals, and all complementary tests. This is only copayment for medication adjusted by income with a maximum monthly payment from 8 to 60 euros for retired citizens and no copayment for those unemployed. As well, a comprehensive primary care basket of service including health problems, treatment, diagnosis and follow-up, where the patient needs, that means in the health center, home or nursing homes, new services as clinical ultrasonography, dermatoscopy, retinography, minosurgery, end-of-life support at home, including euthanasia, chronic complex patient programs, health promotion and social prescription schemes involving the coordination with the community health assets providers, as Josep Figueroa mentioned about outside the health system, a safe use of medication through polypharmacy review plans and the prescription strategies starting to program to reducing low-value practice in primary care, and other services provided by midwives, physiotherapists, and other professionals that are joining our PHC teams to increase this basket of services. And finally, the increasing feminization of primary healthcare workforce. And tomorrow we'll see it's a great day for all the family professionals in Spain, and that are mainly women.
Very good, and I'm very glad that you mentioned universal coverage for primary healthcare. That's very, very important. Joseph, let's come to you with this. Our colleagues mentioned a number of important pillars of successful and strong primary healthcare systems. And these pillars we discussed proved to be critical during the pandemic for primary healthcare to continue to function even when other government and private services were shut down. The observatory launched a fascinating resource during the pandemic, the Health System Response Monitor, and analyzed together with us how countries were transforming their primary health care even during the pandemic, even those difficult times. What were some of the lessons learned?
Yes, exactly. Well, thank you for mentioning this resource that we put together actually with you at WHO and with the European Commission, where we monitored the responses of the health system. We have a number of, sorry, I'm advertising our work, but that's what I think is useful for our viewers. So we have this volume looking at the main experience, a lot on primary health care, and this one that has an article with you, Melita, as well, looking this special health policy issue, all free downloadable, that is looking at particularly the lessons from primary health care. But indeed, Melita, if something the pandemic demonstrated is those countries with more effective, strong primary health care dealt with the pandemic much better, starting with the universal access, of course. But as you said, Melita, and as our colleague said, these pillars that are core to primary health care have been fundamental in addressing the pandemic. We see the roots of the success of primary health care in the pandemic precisely in those pillars. And they've been mentioned: multidisciplinary primary care and seamless integration, community care and specialized care. That was central to deal with the COVID patients at home, monitoring them at home, drawing on community resources, drawing on civil society, as well as connecting with specialized, with acute services, in many instances, keeping patients at home when needed, when required, and not overloading the hospital system. So that integration, that multidisciplinarity with prevention, with social work, with community work, and so on, has been fundamental. And on prevention, again, the ability of primary health care to coordinate with public health, the ability to, the skills and ability to work on prevention has been central. In many countries, primary health care has been key on remote triage, managing testing, remote home-based monitoring, as I mentioned, more treatment of mild and moderate cases, key in surveillance, data collection, and monitoring the pandemic, and in vaccine delivery, while at the same time they managed to deliver the non-COVID essential services. In fact, we've seen many innovative ways of dual delivery. We've been seeing many innovative ways to have new pathways. But also new, more innovative primary health care in many of our countries have adopted digital innovations to treat, to monitor, and to do better risk communication. So our primary healthcare providers, like in Spain actually, have a number of digital solutions to wider patient engagement options, remote consultation, remote digital monitoring, as I said in many instances. Clearly, e-health records have been fundamental, and electronic prescriptions. And finally, another main lesson, again as part of the fundamentals of primary health care and equity, is the way that primary health care providers help to prioritize and identify the vulnerable populations for outreach. So primary health care, with these e-health records, with all this data, was able to identify those patients more vulnerable, with more risk, to ensure targeted health services, as well supporting them with community resources and social work. So if anything else, the pandemic has demonstrated that those fundamental pillars of primary health care were key on its effectiveness.
Thank you very much, Joseph. And while you were talking, my colleagues put in the chat all the resources you have been mentioning. We have with us today a number of policy researchers, and I really recommend checking out the Response Monitor, which is a fantastic resource for cross-country research. listening to you, I am really struck by these amazing primary healthcare systems that are doing so much, that they're designed so well. How come that with these strong pillars, now we're in a phase where primary healthcare is in the news on a daily basis? I read only 2 articles from your countries this morning only about health workforce shortages, difficulty to recruit people to primary healthcare setting, difficulty to motivate young people. What is happening? What are the challenges you're facing? What is the narrative in your country? Why is this happening? And Christina, let's start with you.
So, of course, we're no exception. We're facing a lot of challenges in Lithuania. And currently, if we look at the statistics, about 39% of our practicing family physicians are above the age of 65 or older. That means in the upcoming years, we are doomed to face a new reality where a lot of our staff will retire and go out of the labor market. For us currently practicing physicians, and including me, the junior ones, that means increased workloads because the academia is not able to provide high numbers or such high numbers meeting demands from the general public of the medical graduates. So for those increased work demands, we're already seeing the numbers that our staff has been experiencing burnout. In some regions of Lithuania, the burnout rate for primary care settings reaches up to 80%, which is very worrisome and very alarming. Of course, we have quite a bit of shortage of finances currently coming into the primary healthcare sector because our system, like a lot of others as well, is per capita based, or we have our lists and this is how we earn our income. But years going by, we realize that we provide more and more services to our patients and we lack those funds and finances that come in solely because of the patient being in the list of your clinic. The other thing is that we're facing as a challenge is communication and inclusion. And that is a bit of a paradox because in previous years, in previous decades, primary care representatives and stakeholders would be very much on board within planning the healthcare, let's say, future. As of recent years, with the pandemic ongoing and clinicians focusing on providing healthcare services to the patients, we have seen that this communication between policymakers, financial deciders, and everyone else, and healthcare professionals among the primary care sector has been failing. So we need to look for those really new ways how to communicate and get those primary care teams on board in planning the healthcare future. The other thing is that I feel like in Lithuania we have for many years been discussing the fact that we need to have patient-centered care. But this relates to my first point. We really need to have the healthcare being human-focused, not only patient-focused, and invest into our personnel and our well-being of the staff as well.
Indeed, those are very important narratives that I think will be echoed in some of the other countries. Pilar, let's come to Spain. Are you seeing similar trends as Lithuania as the source of the problems?
Well, regarding Spain, there are short and long-term challenges as well involving all the stakeholders. First of all, to address human resources issues. Without competent and motivated professionals, there won't be quality in primary healthcare. In Spain, we do not have a shortage of doctors. We export competent healthcare professionals to Europe due to our work conditions and salaries. We do have 46 medical schools. The specialty of family and community medicine offer a third of the vacancies for residency programs in 20 and 22. However, 8.5% of them have not been filled. We need to make attractive family medicine, to make a positive discrimination to support, retain, and recruiting policies for family doctors, increasing salaries, average salary of 2,500 euros a month, and 20 to 30 euros per hour on call in primary care, incentives for a professional career with the possibility to combine clinical practice, partial release for research, university teaching, teaching family and community doctors and nurses residencies, establishing family medicine departments as medical schools, improve working conditions regarding teamwork, and redefining coordination of new roles, promoting organizational and management autonomy, as Christina said, with a strong clinical and organizational support or leadership for family doctors. An important concern is PHC teams is the relocation of non-qualified hospital nursing professionals at the end of their career in primary care that can make a change of culture organization, and bringing together health for other departments, coordination with social care, as Josep Figuera said, which is to define the role of primary care teams with long-term care facilities, coordination with public health, to share information health systems, building a trusted relationship among primary care and public health, to have primary care professionals in health policy decision-making commissions or committees. The pandemic showed that all politicians and health managers consider primary care to be in the heart of the system, but words do not follow the deeds. And despite the fact no common information system have been developed at European level for primary health care in the aftermath of the pandemic. And for example, a high investment in mobile applications for COVID-19 in almost all countries, with no of them connected to primary care level in countries. Finally, to invest in an adequate PHC business case means PHC information system to ease decision-making and current information, and to improve budget allocation based on a model that incorporates the community context with the main social determinants, as you said before, and the current health demands, and flexible to be adapted to the real needs. It's just some ideas. Thank you.
Indeed, and there is some common thread between the two countries we have heard. One is that the financing, the resourcing hasn't kept up with this really marvelous transformation of primary healthcare, doing more and more both clinically, but also addressing psychosocial problems in the community. And the second one is really the health workforce problems. We really need to think more deeply about them. Catherine, let's come to you. And at the beginning in your elevator speech, you used the metaphor that we built that great house, but we built the wrong house. Perhaps you would like to return to your metaphor. How are the problems and challenges looking at this point in Canada?
Yeah, thank you, Melita. I think I'm struck actually by the similarities in the challenges across the world, really, around, certainly in Europe and Canada, and I suspect many other parts of the world. So for us, I think one of the big challenges is, unlike some of the European countries, we don't have a guaranteed access to primary care. So, in the school system in Canada, the school you send your children to is determined by where you live. In Canada, we don't have that similar assurance that if you live in this area, this is the clinic where you will find primary care. And that's a problem. It means that 6.5 million Canadians don't have access to primary care, to a family doctor. Like others, a big part of our problem is the model of care. The solo physician model is slowly being replaced by teams, but we don't have enough teams. In the province of Ontario, where I live, only about a quarter to a third of the population has access to teams. And when people studied the value add of teams, there was some debate about whether they were really of value, in part because we keep thinking about saving money rather than really getting really good value for care, which is the other problem. I think one of the challenge, which really goes back to being victim of our success, is that primary care, both physicians and nurses in primary care, have been wonderful elastics. We've heard how we just keep adding and adding, and I think our elastic is actually quite stretched now and about to snap. And the reality is that our young colleagues, both nursing and physicians, are not really interested in spending most of their work life completely extended as an elastic. They want a little bit of looseness, and I do want to tip my hat particularly to nurses here, because of course it is the collaboration with nurses in primary care that allows us to do so much. And the last thing I want to come to, Melita, is really this notion of funding and fee-for-service. The way we pay physicians, certainly for those who are still paid by fee-for-service, does not work to deliver the kind of care that people need to address the social determinants of health. And the capitation model is really in its infancy in our context. It doesn't take complexity into consideration, for instance. So those are some of the challenges that we face here in Canada.
Thank you very much, Catherine. Indeed, and a number of European countries can identify with that, because not all European countries are using capitation and some performance-based pay to finance primary healthcare. And indeed, we have been arguing for a number of years that it is really time to take another look how we pay and purchase primary healthcare services, because neither models, as we heard from our panelists, are satisfactory at this point in time, when the agenda is much greater than when those payment mechanisms were designed. This is an area of work that we're going to invest in the future, so please hold that space. But Josep, I'd like to bring you in. Help me reflect and summarize a little bit what we have heard. To me, it sounds like from our panelists that the problems they're facing are not really just short-term pandemic-related problems, but they're rooted more deeply in longer times, more structural issues in how we design primary healthcare systems. And the pandemic has brought to the fore and accelerated and magnified these problems. What would be your reflection on this?
Exactly. You said it and very well, Melita, just to echo your words. The pandemic has been just another shock to the system of the many shocks we had in the past, and unfortunately the future shocks, not just in terms of pandemics, but also in terms of financial crisis or even war, and certainly environmental impact. So in some ways, there is a silver cloud in the pandemic as an opportunity, as a reminder, as the canary in the mine, reminding us to some of the long-term deficiencies of the health system that need to be urgently addressed. Of the many we heard, and I like to focus what Pilar was saying and the others about the staff issues, the staff struggling with the workload, the staff burnout. We heard a lot, we talked a lot about the staff being at the core of the system and the resilience. And this problem is particularly important in primary healthcare. As we heard from Pilar, and it happens elsewhere, the GP, the family practitioners posts don't get filled. And we understand that. We understand that because primary healthcare is tough. We don't pay them well enough. The working conditions are not flexible enough. In a moment of feminization of the profession, the day of the Women's Day, we need to find much more flexible working arrangements. We need to have much more support to that staff. We need to have more training to that staff. We need to support their mental health. We need to strengthen the skill mix. Primary healthcare is not, as we know, not only doctors. There's a wide range of professionals around them to support that. And indeed, we need to attract people to the profession. One of the main problems that we discussed before, Melita and colleagues, is the way that we recruit our medical students. Medical students should be recruited not only for their high levels of biology, physics, of math, but their humanity, their ability to communicate. Medical students in the first year, they should be exposed and work in primary healthcare centers from the very beginning. So there's a lot that can be done to deal with this vocational real crisis. Also to remind you, in many countries, as much as 50% of the GPs are above 55. So this is a very urgent issue that the pandemic has reminded us. The pandemic has reminded us, well, on many other areas that we've been looking at with the regional office. We've been looking at digital. We've been looking, for instance, at backlogs. We've been looking at how do we address the enormous backlog provided, caused by the pandemic. So as we know, countries were already struggling with that. The pandemic, with the disruption of essential services. In some countries, as many as 40% of the essential services were disrupted, has increased the waiting list massively. We've been looking at that. We've been looking at some of the solutions. And perhaps, Melita, in 30 seconds, I'd like to highlight that backlog and waiting times is not just about hospitals. Actually, a lot can be done in primary healthcare. So we've been looking a lot about, for instance, the importance to strengthen discharge policies, very much in primary healthcare and community care. So we have shorter lengths of stay and proper support at home. We're looking at remote consultations to be able to address these problems earlier on. We're looking at prioritization of these waiting lists and who needs to be actually in that waiting list. We know that in this waiting list, some patients no longer need to be there. We're talking about home care and supporting these patients. We're talking about community hospitals that could deal with daycare surgery, very much supported by primary healthcare, that could deal with minor conditions that are adding to the waiting times. So there's a lot that can be done there. But for that, of course, I said that we need much more resources, we need much more support, particularly to health workforce, more digital, more training, and so on.
Thank you very much, and that's the perfect segue to our final round, which is to think about the future. So we have these amazingly built systems that perform very strongly, have built population trust, but it sounds from your narratives that the resources, the investment haven't kept up, and the health workforce policies need a new and fresh thing to be fit for the current decade. In this final round, I would like to think about what we can do to stabilize these systems, and whatever policies we choose will have very important implications beyond your own countries, because all eyes are on the well-performing primary healthcare systems. It seems to me that there are two types of policies we can think of: short-term policies and longer-term policies. Shorter-term policies that can focus on managing this very high level of demand with better demand management strategies that would give a little bit of immediate relief for the workload, while we are pondering what are the root causes of our system, how to rethink the foundation of our house for primary healthcare that's fit for its current tasks. And I give a 2-minute break for our panel now, and I'd like to watch together with you a video. We have invited one of our key experts, Dr. Rebecca Rosen from the Nuffield Trust in the United Kingdom, to narrate to us what are the demand management practices she uses in her practice. Let's watch it together.
There are various ways in which we're managing demand for appointments with doctors. Firstly, many practices have introduced a digital front door. That is, patients submit an online consultation, or if they can't use a computer, they phone or walk in and the receptionists do the online consultation for them. And then one of our experienced doctors reviews all the requests and decides if the person needs an appointment or whether they can be managed remotely with information or advice. In a well-run practice, about 40% of the requests for appointment can be managed remotely through the computer without needing to book them in. A second way in which we're managing demand is through skill mix. We don't have enough GPs in this country, so we are recruiting other clinicians, physiotherapists, pharmacists, paramedics who are good with minor illness or injury, mental health practitioners and others, to become part of a primary care team that is supervised by a senior experienced doctor. If a patient rings up or contacts submits an online consultation with a simple joint problem or minor anxiety, they can be booked in with a member of the multi-professional skill mix team, and we save our GP appointments for people with more complex problems. The third way in which we're managing demand is through what we call care navigation. If people want an appointment for a minor self-limiting illness, acute conjunctivitis, insect bites, simple allergies, the reception staff have been trained to identify conditions for which they can advise a patient to seek self-help treatment from a chemist or to buy an over-the-counter medicine. And then finally, we're looking very closely at practice efficiency, at making sure that the way we use our appointments is as efficient as possible. For example, if a patient needs an annual medication review, the reception or the booking team know that before they're booked in, they have to have had a series of blood tests, have their blood pressure checked, maybe 1 or 2 other checks. They don't book the appointment until that's been done. So where we used to have perhaps 2 or 3 appointments used, now we make sure there's only one.
It's very refreshing to hear these pragmatic approaches to managing demand, and in the short term they may provide some relief from the current problems we are facing. However, for our final round, I would like to look into the more distant future of how we get the structure right, how we get the pillars right, how we get the foundations right. Christina, please go first.
Thank you. So I was very glad to hear some of the pragmatic recommendations from our colleagues in the UK. To touch upon the main pillars that I mentioned that are the cornerstones of primary healthcare in Lithuania. So I would like to start with training and education. So I'm happy to report that in Lithuania, and perhaps what Joseph has mentioned, that first-year medical students should be already exposed to primary healthcare. So for now 3 years in a row, one of the main universities in Lithuania has invested and redone the program of medical education, undergraduate medical education, and now our first-year medical students have primary care rotations. They do observational practices and they work within teams. Just right now, today, we had started a new round, so first-year medical students are actually staying in primary healthcare settings in various ones, and in larger clinics and smaller clinics in various settings, both international students and local students. So we have quite loads of interesting outcomes from that, but definitely positivities, and we're hoping for that to continue in the future and hoping that it will have a positive outcome to sort of increase even more our training slots for the specialty in family medicine in the future. The other very important thing that I would like to mention is that we need not a revolution but evolution in primary healthcare. In Lithuania, we had a very good, stable ground. We just need to build upon it, and we have to make sure that we involve people who are working every day in the field to sort of consult the process. We absolutely need to involve the patients, and I'm also happy to report that we have now a beginning of what we like to refer to a national agreement for our healthcare in the future, which is led by our Junior Doctors Association, so our future physicians, and we put a lot of hope into this process to sort of sit down together nationally and agree upon where we're heading towards. And this will have a lot to do with primary healthcare as well, because we're the ones that serve the patients closest to them. The third thing that we envision for the future is innovations. Currently, we have e-health, we have data collection, we have various mobile health applications and things like that, and they will naturally progress, and we're happy about that. With the artificial intelligence tools, we're also happy to see where that's heading and sort of how that can assist the workload burden for our teams. However, we need to collectively understand that new innovations and tools should be an assistance rather than just a copy of what has been wrong in the previous years. So it's wrong just to digitalize the old habits, but we rather need to find new innovative solutions for the future.
Thank you very much, Christina, and I want to thank you for your leadership in the younger generation of family doctors. And what you said at the end is so powerful, right? Because the solutions are not necessarily to return to a mythically perfect and ideal past, but to really think about what is the need of the future and move towards new instruments and new tools. Pilar, what can help us in Spain?
Well, primary healthcare system in Spain has a solid foundation on core values. We have the diagnosis, and that leads to the model crisis, and crisis is always an opportunity to improve. However, we need a plan on how to address. Surely, the most interesting debate at the moment is how it can be done. Some ways are to move together, greater collaboration among healthcare organizations, the World Health Organization, The European Union, scientific societies, universities focus on training and advanced competencies, specifically in primary care for new roles. It may be needed a European regulation to guarantee appropriate training and competencies for these new professional roles, to increase coordination in primary care teams, policies for recruiting and retaining healthcare professionals by improving working conditions, professional careers and salaries as a positive discrimination policies, perhaps making attractive for young professionals to work in primary care. A higher budget allocation, although World Health Organization recommends an investment of 25% of the healthcare budget in primary healthcare, European countries have not implemented it. So a strong focus on prevention and health promotion, as Dr. Figuera said, will help to reduce the burden of chronic diseases and improve our overall health outcomes. Nevertheless, in Europe, the budget for prevention is less than 3% of the healthcare budget, so it's clearly insufficient to address preventive care. And surely, embrace innovation and technology will be critical for adapting primary care for the future, but oriented to improve the way we care, leveraging data analytics to identify high-risk patients and improve their care plan, for example, to have a risk map to address home visits or address medication risks, among others. We will need to develop new care models that incorporate technology. And we have not to forget, we need time to learn together as teams, to analyze and make improvements with quality management tools, reporting and learning system to notify, to report patient safety incidents to improve a safe care, building up a new primary care who learn and improve for the way it deserves the care. By taking these steps, Spain can ensure that its primary health system continues to provide highly quality, accessible care to patients while adapting to future needs. I think it's a commitment to all to attain it, and with illusion, of course. Thank you.
Indeed, and those are very important policy steps that are more universally applicable at this point in time beyond the borders of Spain. Catherine, how about in Canada? How do you see the way forward?
Well, I think a lot of what has been proposed by the other panelists are absolutely the things we need in Canada. I want to focus and go back to Christina and Joseph's comment about the humanity of the equation, because undoubtedly, yes to electronic health records, yes to technology, yes to AI, yes to structures, yes to everything. Ultimately, primary care is about good human care. And so that means strategies that strengthen the humans that deliver care and models that are responsive to the humans that receive the care is really what's needed. And so I would recommend a continued investment in clinical and human excellence, which builds trust, which then builds utilization. And I think also building on not just the number of staff. We talk about teams as if they are meant to compensate for the lack of physicians. This is not the case. The teams are there because the skills needed to deliver good care have changed, and we need a broader scope of expertise, and so we need to invest in that and invest on how to work well together. We need to make sure that that not all tasks are done by everyone, but that the tasks that don't require perhaps the physician knowledge are done by somebody else, and really understand how to organize this. We need ways to promote relationships within the team and with patients. We need funding models that actually enable all of this. And I think lastly, this is my last comment, I think those of us who are passionate about primary care, we need to make a point of actually underscoring how rich it is. We often, I've heard the analogy that doing family medicine is a bit like eating a lobster with 16 shells. When you get to the meat, it is so good, but these days you have to work hard to get to that meat. And so for those of us who love the lobster, I suggest we take our space and really highlight its incredible value as a profession.
Thank you very much for bringing in that human aspect. I think it is indeed that a way in which primary healthcare is so fundamentally different from other aspects of healthcare and medical care is this human aspect, the need to communicate and connect. Joseph, I think for the last question, I'm going to ask you probably the most important question of this talk show. Those of us working in primary healthcare policy often are struck how difficult to get the right technical solutions on the policy agendas, how difficult it is to get policymakers to do the right thing and invest and prioritize in primary healthcare. What are your thoughts on this? If we know the answers, what can we do to get these answers on the agenda and resource them?
I wish I knew, but I have some ideas. I think my 3 recommendations would be communication, communication, and communication. I think, and you, Melita and colleagues, are the exception to the rule, we're lousy at making the case for primary health care. We're not good at presenting the advantages, presenting the outcomes, presenting the impact of primary health care to our policymakers and beyond the Ministry of Health to other sectors, to the Ministry of Finance and Prime Minister. I was wondering now, Melita and colleagues, whether the COVID that has linked, again, trying to see a silver cloud in this awful storm, the COVID that has shown the importance of health in cohesion, in security, in sustainability, and the need to strengthen health and health systems can be a good entry point for investing on primary health care. Because, Catherine, using your very beautiful example of the house, in some countries the house is just fine. It's just mentioning, as you said, the pipes are run down, the door is not opening anymore, and there are no people to clean it or to house it anymore. So the house is good. The house did its job. So if the house is run down, no one will want to go to the house, and they would prefer to go to the next house, the big hospital with shiny walls and so on. So we need to invest on that one. And to invest on that one, now I gone into a wrong direction, but to invest in that one, Melita, as you're asking me, I think it's important to link this concept of health, primary health care and well-being, I was saying at the beginning, primary health care and economic development through health, primary health care and access, patient-centeredness, community involvement, primary health care as acting on determinants, and particularly primary health care as value for money. The evidence of primary health care as value for money is all over. We need to be much better at showing the value for money in primary health care, at the decrease in referrals, at the good resolution of primary health care of many problems that will not need more expensive hospital care, with the more digitalization, the ability of remote consultations and resolve more problems. Although, Catherine, of course, I agree fully with you, at the end of the day, it's about the human contact. But there's so much evidence we have about primary health care being value for money, primary health care creating satisfaction, empowering, equity. All these elements are fundamental for economic gains, for sustainability, and overall for well-being. Why are we so lousy on making that case more effectively? I think this is where we should focus a lot of our energies. And actually, let me mention, Melita, Catherine, you're both editors of this great volume. Is primer on primary health care, and actually what we're trying to do is going to be launched at the end of this year with Euro headquarters and the observatory. We're trying to put best practices where to invest on primary health care. But again, we need to make the case, we need to attract the resources, the human resources and the financial resources to prove that this house can actually resolve many of the important problems of our population and our health system.
Thank you very much, Joseph, for those very powerful final words. And indeed, let's take this unique opportunity in this post-pandemic period when attentions are high on public health and primary healthcare. Let's do a better job making the case for why invest in primary healthcare. And let's renovate this house that we have built and in many countries are working very, very well. I thank you for your time, for your rich reflections, for sharing with us your thoughts. And now I would like to invite all of you to join our breakout sessions. Some of our panelists will also be able to join so you can interact with them. We have a breakout session in English language moderated by Dr. Tony Dedeu and Jose Cerezo, and a breakout session in Russian language moderated by Dr. Arnoldas Jurgutis. My colleagues are pasting the links into the chat, so please follow them. And we will keep the main window open so you can interact with us if you have trouble joining the breakout sessions. When you close the main window, there will be a pop-up survey with a few questions. Please fill this out. Your response is very meaningful for us. We always analyze how we do and how we can do better. Thank you for joining us today and see you on the other side in the breakout sessions. Have a good day.